what's new in terms of screening and diagnosis, specifically talking about PSA, and then diagnostic testing. A number of these tests are things that have just come around in the past 5 years or so. Excuse me. And then also to talk about treatment, and I'm going to talk about a few specific things: focal therapy, a couple of differences in radiation therapy, and some of the things in drug therapy. Now, to begin with, though, let's talk a little bit about the background of why this is important. And that starts out with the numbers. Why is prostate cancer important? Well, in the US, over 200,000 men per year are diagnosed with a prostate cancer every year. About 31,000 men die from prostate cancer each year. So that means that 7 times as many men are diagnosed as die from prostate cancer. So the good news is the vast majority of men do not die from prostate cancer, but that 31,000 still makes it the second most common risk of cancer death in men. So it's still very important. Now here's the important part about the time of diagnosis. These green bars across the screen show the survival by stage. And what you see is that for localized prostate cancer, 100% of those men are alive 5 years later. With regional prostate cancer, that is spread outside the prostate, but still in the local area, so to the seminal vesicles, even to the lymph glands, 99% of those men are alive at 5 years. But that drops to only about a third if the cancer has spread to distant areas, which primarily would be into bones. So there's a very big difference between what goes on between men who are diagnosed with localized or regional prostate cancer and those who have distant prostate cancer at the time of diagnosis. And we know that prostate cancer can be a slow-growing kind of tumor, but what we really need to do is to separate out this group of men who may have a more aggressive or faster-growing kind of tumor. Just a quick discussion on anatomy. The prostate is a very small gland that's kind of localized right in the area of waste treatment in the body. So this is a cross section. So if you split someone right down the middle, this is kind of what they look like. The front of the body here, the pubic bone, and right behind that is the bladder. Behind that is the rectum, and then further back is the tailbone and the buttocks. Tucked right under the bladder, right in front of the rectum, is the prostate gland. That's the reason that on a rectal exam, we can reach in and feel at least this part of the prostate. And then right above the prostate are the seminal vesicles. And the main function of the prostate and seminal vesicles is to make and store the fluid that carries the sperm. And that gets transported through this seminal duct into the urethra. And the urethra is the tube that goes from the bladder out the penis. So it's in an important location right next to a lot of important real estate. And that's the biggest problem with the prostate gland is the location. So to talk a little bit then about screening and diagnosis, how do we find, you know what, it says it's not sharing. So Ashley, on mine, it looks like it's sharing, but I don't know if it looks like that on anybody else's.
I still see it, yeah.
Okay.
It looks like in the chat it says they can see it as well, so I think we're okay.
I'm having a little bit of trouble getting the slides to advance, but we'll try again here. So for the screening and diagnosis part, I'd like to specifically talk a little bit about PSA, because PSA has been around for quite a while, but is still very important. And then some additional diagnostic testing that is new, that has not been around for a long period of time. So let's dive into PSA. What is it? It's prostate-specific antigen. It's a protein that's made by prostate cells. The function is to keep the semen liquid. It keeps the semen from gelling up. But the protein is made both in prostate cells and in cancer cells. So it's not just made in prostate cancer cells. So it's a marker of of prostate cell activity, not necessarily prostate cancer. However, the PSA begins to rise with certain circumstances, anything that causes some irritation of the prostate. The older a man gets, the bigger the prostate gets, and thus the PSA goes up as well. If there's any kind of activity in the prostate, for example, ejaculation, that can make the PSA go up. If there's any trauma to the prostate, and you may not think of these things as trauma to the prostate, but riding a bicycle or having a prostate exam would cause some trauma to the prostate. But also infection or inflammation can make the PSA go up. And prostate cancer can make the PSA go up as well. Now, there are multiple types of PSA testing. The kind that's been used most commonly is the total PSA. And that's been done using something called a screening PSA. And that typically tells us the value to the 10th place. So you'll get a level that's something like 3.1. That's very valuable in helping to separate out men who have a low risk of a prostate cancer from a higher risk. But it does change with age. We used to say that 4 was the magic cutoff, but we know that a man who's 50 shouldn't have a PSA that's above 2.5. But a man who's 70 could have a PSA that's 5.5 and still be normal. So this is now age adjusted. And then there's a type of PSA that's called ultrasensitive, where that will read out to the 10ths or the 100ths places. And that's primarily useful for men who've had their prostate removed, where the PSA should be at a very low level, basically 0. There's also a way of seeing which of the PSA is attached to proteins and which of it would be just free in the blood. And the more free PSA there is, the less likelihood there is of a prostate cancer. For some reason, the PSA that's made in prostate cancer tends to get bound to proteins more frequently. So if you have a high amount that is bound to the protein, it increases the likelihood that there may be a prostate cancer. But that's also dependent upon the level of the PSA. And then there are a few new tests that are out there, the PHI and the 4K. The PHI is Prostate Health Index, and it measures not only the total and free, but also a precursor to the PSA. And then 4K, which also measures some components of the PSA. And these are useful in determining whether an elevated PSA is related just to normal PSA, or if there are changes that would make it more likely to be associated with a more aggressive kind of prostate cancer. These last two would not be used as part of initial screening, but might be done depending on if the PSA is elevated. In 2008, there was a group that's called the U.S. Preventative Services Task Force, which came out with a recommendation saying that men over 75 shouldn't be screened for prostate cancer. In 2012, they upped the ante and said, PSA is not really a good test for screening, and so we don't recommend doing this at all. Now, that was based on kind of societal overview of the PSA, and actually kind of a misinterpretation of some tests. There weren't any oncologists, urologists, radiation oncologists on this panel, and there weren't a lot of epidemiologists even on this panel. And so these recommendations came out in 2012. By 2018, though, the panel backtracked somewhat because there had been a lot of pushback. A lot of people had shown them that the data actually shows that there is a benefit to PSA screening. And so the USPSTF backtracked and said, okay, we'll give it a grade of C for men who are ages 55 to 69, but you've got to talk to those men about not only the benefits of prostate screening, but the potential harms of screening. Now you might think, well, what potential harm could a blood test cause? The potential problem would be it can cause some anxiety if the PSA is up, but more than that, it may cause some men to undergo testing, including biopsies, where there's a risk of infection when they really didn't need to have that. So that's the part that involves the discussion. But at least at that point, they said, okay, PSA screening makes sense. but still not for any men who are over 70. Now, what I'd like to point out is the USPSTF is taking society as a whole into consideration here, including costs. And so this may not apply to any individual person. Basically, they're saying that the cure rate, the 5-year survival rate's really not going to be changed much by doing the PSA screening. As we talked about, the prostate cancers can be slow growing, so that may actually be true that the 5-year survival is not changed, but it may change things in the long run. So this is a study that looked at something called the Surveillance Epidemiology and End Results Database. This is something that the Centers for Disease Control maintains, and it looked at hundreds of thousands of men with prostate cancer, looking before the change in the screening recommendations and after the change in the screening recommendations. And what happened is that after those screening recommendations came out in 2012, that the number of men diagnosed with metastatic prostate cancer had increased. So in other words, the number of men who were diagnosed with localized or regional disease actually stayed stable or went down a little bit, but the number of men who were diagnosed with metastatic disease where the cure rates are not as good had significantly increased. So that tells us there still is a role for PSA screening. This is a relatively easy thing to do. And so the guidelines are now, for most men, PSA at the age of 50 is appropriate, and then that can be done every other year or so, depending upon risk factors. For men at higher risk, those with a family history, the screening should be done earlier. In some men with a high family risk at age 40, and for Black men, African American men, the risk is higher than the Caucasians or Asians, and so their screening should start at 45. So those are the recommendations from the American Urologic Association and several of the other medical organizations who are involved in screening. So let's talk about what happens if the PSA suggests there's a potential issue. What should be done? Well, in the past, if there was a suspicion, so if there was a nodule felt in the prostate or if the PSA had gone up, the next thing that would be done would be a biopsy. That's changing now. In general, now we recommend that the next thing that should be done is imaging, that is an MRI scan of the prostate. So this is magnetic resonance imaging. And basically what this uses is magnets and radio waves to tell the composition of the cells in the area that's being tested. And so an MRI scan can look at the prostate. Now, they used to have to put what's called an endorectal coil, which would be something into the rectum to do this, but that can be done without an endorectal coil now. So you can just do things that are all external. So the patient is just laying on the MRI table. And if there is an abnormality found in the prostate, there's a score that's given to it that's called PIRADS, and you can see the acronym stands for Prostate Imaging Reporting and Data Systems. And if a PIRADS score is 1 or 2, it's really unlikely that this represents a cancer. But if it's 4 or 5, it's more likely that it's a cancer. 3, of course, sits right on the fence. But if you have an area that's a 4 or 5, that's something that should be biopsied. And the change in biopsies has gone from just doing systematic biopsies, that is, taking some pieces at the top, middle, and bottom of the prostate on either side, to taking not only those pieces, but also specifically targeted biopsies of the lesions seen on the MRI scan. And these are called MR ultrasound fusion biopsies. There still should be those systematic biopsies done because that combination gives the highest likelihood of finding a clinically meaningful prostate cancer. But then what do we do with the biopsy results? As with treatment, it's often useful to get a second opinion. And one of the problems when you have the pathology reading is if you give the same slides to 100 pathologists, only 70 will agree with each other. So there is some discrepancy because it's a somewhat subjective kind of evaluation. So genomic testing is something that can be useful to help determine which of those prostate cancers are more aggressive and which are less aggressive and maybe don't need treatment. And there are actually four of the genomic tests out there. The three most commonly used are Decipher, Oncotype DX, and Prolaris. They work in slightly different ways, but basically what's done is the slides from the biopsies are tested, and the cancer cells on those slides are tested to see which genes are abnormal. Those are then compared to databases from biopsies from other men where the genes have been tested, and then those men have been treated and followed for a long period of time. So this tells us not just what it looks like, but how it's likely to behave. So for many men, doing this genomic testing can help assess the aggressiveness, and it may help tell whether a tumor is really slow growing so that active surveillance could be done, or if it's a more aggressive tumor that treatment needs to be done, and can help make decisions about treatment as well. Now, if a prostate cancer has been diagnosed, typically in the past, we would have done a CT scan of the abdomen and pelvis and a bone scan. And those are different ways of looking at things. The CT scan is a CAT scan of the abdomen and pelvis, which basically tells you the structure. It's looking for abnormalities like enlarged lymph glands. The bone scan is looking for changes in the bone, and so you get an isotope that goes to anywhere that the bone turnover is active. Those tests are good, but only at a certain point, only when the tumor has reached a certain size. When you have a very small tumor, it's not going to show up on a CT scan or a bone scan. There are a number of tests that have been looked at over the past 15 years. There's something called a Prostate scan. We started looking at PET scans, and PET stands for positron emission tomography, but it's basically a scan that combines something like a CAT scan with something else that is a dye or isotope that goes to certain areas of the body. And the one that's used most commonly, for example, for lung cancer, breast cancer, esophageal cancer, or head and neck cancer, is a sugar, a sugar that has a radioactive label on it. And your heart uses a lot, your brain uses a lot of sugar, your muscles would use a lot if you're active, so you're resting during the time of this test. But a lot of cancer cells use a lot of sugar as well. With prostate cancers, because they're slow growing, there are a lot of the prostate cancers that don't use a lot of glucose. And so a lot of times a regular PET scan won't show them, but there are markers that can more readily find prostate cancer cells. And one of those, the best one, was introduced and FDA approved about a year ago, which is PSMA PET scan. It stands for prostate specific membrane antigen. So this is a marker on the membrane of the cell. And basically what the isotope tracer does is find that marker, and then it gives off the energy with a radioisotope, which can then be imaged to show us where that's being taken up. Now, this will show normal prostate cells as well as prostate cancer cells. The prostate cancer cells tend to have this in more abundance. As an example, you have the scan on the right, which is the CAT scan looking from the front of the body, the PET scan part also looking from the front of the body. And there's this area in the left side of the pelvis, which is showing up, and you can see on the CAT scan, it's kind of just above the bladder in one of the lymph glands on the side of the pelvis. And that's a relatively small lesion. That's not necessarily something that would be shown on the CAT scan to be abnormal. But this allows us to localize those things that might be outside of the prostate. And this is a test that, although it was FDA approved a little over a year ago, it is approved by a lot of insurers, including Medicare, as an initial initial testing evaluation for patients who've been diagnosed with a prostate cancer. So let's switch gears a little bit and talk about treatment. And I'm going to talk about a couple of different kinds of therapy. I should note that the robotic surgery is not really a new procedure. That's been around for more than 15 years and is the most commonly done type of surgery. Radiation therapy has been around for about 100 years in treating prostate cancer. And so there's a standard way of doing the radiation therapy. So those are really not new, but I want to talk about some changes in local treatment. So we'll start off with focal therapy. The great thing about focal therapy is that it treats the area of the abnormality. It avoids treating other tissues around like the bladder, the rectum, even the urethra. But to do that, you have to have a focus. And so this requires a scan like an MRI scan, which has shown a single lesion, occasionally two lesions, which appear to be localized, and which on biopsies show a suspicious tumor or a tumor that requires treatment, and there is not additional tumor outside of that. So you really have to have a focus or two foci of disease for this to be done. Now, one of the issues about this is we don't have a lot of long-term follow-up, and so this should be done on a clinical trial. One of the issues that we've had in certain types of treatments, they seem really good for the first few years, but when you get follow-up that's out to 5 or 7 or 9 years, then the recurrence rates are much higher than standard treatments. There are multiple ways of ablating a focus, and all of these are that I've listed down here are types of focal ablation. There are others that are coming out, but you can freeze it, that's cryotherapy. You can use ultrasound to heat it up, that's high intensity focused ultrasound, and there are different acronyms for this, like TULSA, which are different ways of doing this high intensity focused ultrasound. You can use a laser to ablate those areas. You can use electricity to basically electrocute those tissues in a small area. You can give a drug or a chemical that is preferentially taken up in cancer cells, but then you use a light like a laser that splits that chemical and becomes toxic to those cells. Or you can put radioactive seeds inside it. So all of these are potential ways of ablating a focus. But again, those are still relatively new treatments for which we don't have a lot of long-term follow-up. In terms of radiation therapy, the primary thing that's changed is the number of treatments. We do something called fractionation. That is, we give the total dose of treatment in smaller fractions, and those are usually given daily over a period of weeks. The reason for that is because in between treatments, normal cells have a good propensity to repair. Tumor cells don't repair very efficiently. So we take advantage of that difference in repair and give multiple small treatments. In the case of prostate cancer, that had typically been done with very long courses of treatment. This is based on studies from 25 years ago or more, where extending the treatment to daily Monday through Friday for 8 to 9 weeks improved the outcomes compared to 7 weeks worth of treatment. So 10 years ago, the standard fractionation was 39 to 44 treatments. There have been a number of studies around the world looking at shortening this course of treatment. And the first of those used something called hypofractionation. Hypo means fewer, so fewer fractions. And those studies have changed the standard of care over the past few years. So when we talk about that, when we talk about the dose, which is given in gray is just the absorbed dose in the tissues, but the dose versus the number of treatments. So in the middle box is conventional fractionation, and we were giving 1.8 to 2 gray per treatment for typically 39 to 44 treatments. So that was the 8 to 9 weeks, and that has been the standard. But there are a number of studies around the world which have shown that we can do a shorter course of treatment of 20 to 28 treatments that gives the same cure rate, same control of the prostate cancer, same low risk of side effects. So that is now the new standard treatment. It's called moderate hypofractionation. There was a consensus statement from urology, radiation oncology, and medical oncology that came out a few years ago that said that basically these are comparable to the older, longer course of treatment and should be the preferred treatment. More recently, we've done something called ultra hypofractionation, and that's the box at the bottom. And ultra fractionation or ultra hypofractionation means giving a lot of treatment each time in a much shorter course. But in those patients, we typically don't treat every day. We typically treat every other day. And so a course of 5 or 7 treatments will take a couple of weeks, still significantly shorter than 8 to 9, 8 to 9 or 4 to 5.5 weeks, but about 2 weeks of treatment and a significantly smaller number of treatments. Now I've got this extra box at the bottom, 6th grade times 6. Did I say this is new? Well, there is a very old protocol that was used in England about 50 years ago. Actually, it started almost 60 years ago and finished 40 years ago for men with apparently localized prostate cancer. And at that time, they didn't even have PSA. So these are men typically in whom a nodule was felt in the prostate, and there was no evidence that there was spread outside of that. Were given a short course of treatment. They were given 2 treatments a week for 3 weeks, and then they were done. And they treated a total of 230 patients, but it was over a 20-year period, so it's only about 10 patients a year. But they showed excellent results in terms of survival and no significant toxicity. And to show you that this works, the picture up at the top right, I didn't just put a picture of Laurence Olivier for fun. He was actually treated with that protocol in the late 60s and survived for another 15 years without any problems from his prostate cancer. So I guess everything that is done now has been done in the past. Well, this ultrafractionation has been done in the past. And there are a number of studies that have come out recently that show that this kind of treatment seems to work just as well in terms of cure and long-term survival, long-term low risk of side effects. However, the downside is that with that treatment, there may be more side effects right after treatment, especially in the urinary symptoms. More urinary frequency, slower stream, more urgency, and occasionally in gastrointestinal irritation of the bowels as well. But those resolve, and in the long run, there does not seem to be any difference with the longer course of treatment. Now, the problem is these studies are mostly 10 to 12 years old. We need to have long-term follow-up. The average follow-up on the longest study is only about 8 years. So we need more data. And we should be able to, in the next few years, to have all that data to determine that whether this is as good as the moderate hypofractionation. One of the questions that we have is it's been mostly used for men with lower intermediate risk disease, but can it be used for men with high risk disease? Those are men where the grade, like the Gleason score is higher or the PSA is higher. One more kind of radiation therapy is something that seems similar to the PSMA PET scan I was talking about earlier, but instead of just using it for a scan, now we have a treatment attached to it. So there's a radioisotope called lutetium-177 that gets attached to this PSMA, and it basically will treat any area that's positive on a PSMA PET scan. There was a trial that was reported about a year ago where men who had advanced disease were given this kind of treatment and had significant improvement in survival. The name of the trial was called the VISION trial. So that's now been FDA approved earlier this year. Now, one of the issues is instead of one of the kinds of PSMA scans that are done now, it has to be a specific gallium-68 PSMA scan that's done. So even if you've had a PSMA PET scan and it shows something, you might have to have another PSMA PET scan to make sure it shows up on this type of scan. And this is the part that I know this had been FDA approved, but I didn't read all the fine print. It has to be for men who've had progression after both hormone therapy and a kind of chemotherapy called a taxane, which in this case is mostly paclitaxel. And so this requires pre-treatment with a lot of hormone therapy and a lot of chemotherapy. Now the issue is when these things are FDA approved, usually they come out and the indication is as the FDA has approved it, but over time that may change. And so I would expect in the next few years that we'll see patients who've not had all of this treatment be eligible for this kind of treatment. It's a kind of treatment that's already given in Germany and in Australia, and probably in the relatively near future in the US, we'll be able to give that to men before they've had lots of other treatment like the taxane chemotherapy. So that's a new kind of treatment. Speaking of new treatments, in the last 5 years, there have been just a huge number of treatments that have come out. And I'm just going to touch on a couple of those, but really the treatment for prostate cancer has changed more in the last 5 years than it did in the prior 25 years. So what's new now? One is that the standard kind of hormone therapy that's used for men with metastatic prostate cancer, cancer that's spread, or advanced prostate cancer, a high Gleason score or a high PSA, that standard has been to use something that inhibits the production of testosterone. And the standard has been Leuprolide, which is called Lupron or Eligard. There are variations on this theme as well, but recently there's a drug called Relugolix, which was tested against Leuprolide in men with advanced prostate cancer. Now, the advantage of the Orgovyx is that it is an oral medication as opposed to the injections. And so one of the good things about that is its side effects, if they're going to happen quickly, but they also stop quickly. And so this is something you could stop right away. Whereas if you've got the injection, it's based in a lipid, and it's going to be given off slowly over a period of months. And the Relugolix also had fewer side effects than Leuprolide in men with advanced prostate cancer. Now, the fewer side effects may not be the ones that you're thinking about. It's not a difference in the menopausal type symptoms, the hot flashes, the moodiness. It's not effects on sexual interest or sexual function. It's more of a reduction in cardiac issues. Now, with Lupron or Leuprolide, the risk of cardiac issues is pretty low, but the Relugolix cut that even in half or less than half. So that's a new treatment that is out there. It is now approved and covered by Medicare. A lot of insurers are starting to cover that as well. In some, they require that you have some rationale, like having already had some sort of cardiac issue, but some of the insurers allow that even outside of that. And another kind of treatment that's come along is intensification of hormone therapy. For many years, in addition to Lupron, we would give something called bicalutamide or Casodex. And that's actually an anti-testosterone drug. It's better than the anti-testosterone drugs from 25 years ago, but it still had a significant amount of side effects, and the improvement in outcome was only marginal. But these new generation of androgen receptor inhibitors or antagonists, so basically blocking the effect of the testosterone at the cellular level, these have shown significant improvement in outcome, primarily in men where the prostate cancer has already spread, but they're now being tested in men where they have higher risk disease. And so these agents have significantly improved the outcome. And for men who have the advanced metastatic disease, it significantly improved the survival rates. For men who have high risk disease, we're checking to see if that will be the case as well. Now, there are a number of other kinds of systemic therapy that I'm not going to dive in now. There are a lot of new things that are on the horizon. Most of these are specifically targeted agents. That is, they are looking at a target that's on the genome, on the genetic makeup of that tumor. And I think these targeted therapies are going to be the things that we see a lot of progress on in the next 5 to 10 years. And these may not be tumor specific. In other words, if you have a PARP genetic abnormality, you may be a candidate for a PARP inhibitor, whether it's a breast cancer or a lung cancer or a prostate cancer. So I think the genomics are going to become more important. The one that I talked about are the ones that are done on the tumor cells per se. There are some more in-depth ways of looking at the tumor cells where basically the whole genome is sequenced. but there are also genetic tests that are done to look at basically the whole body, what's called the germline. And those are more, not necessarily for that cancer that's being treated, but for the family of the man who's being evaluated, because they may tell whether there are certain mutations that may show up in their offspring. So it may be important for their children or grandchildren. So with that, I'm going to stop and turn this back to Ashley so we can have some questions and try to answer those.
Yeah, absolutely. Thank you for that. That was amazing. So yeah, I have a couple questions here. I'm going to swing over here so I can read them. So when under active surveillance, how often are you meeting with your oncologist?
Active surveillance is for a man who's been diagnosed with a prostate cancer, usually a low grade. So it's usually a Gleason 3+3 or 3+4 and a PSA that's not too elevated.
Okay.
And in general, for those men, what we are doing is we are following them to make sure that there's not a progression of disease. And so typically my recommendation would be to get PSAs at routine intervals. My recommendation is about every 6 months. I think if you do that more often, you may create anxiety and not really help things. And then repeat imaging in a year. If you haven't had an MRI scan, that's something that should be done at the start of active surveillance. But the imaging is then repeated in about a year. And if the MRI scan shows a targetable lesion or shows a change, then another set of biopsies is typically done. In fact, we often do the second set of biopsies about a year after the first one anyway, to make sure that there hasn't been something that's missed. And I think it's important, though, to get the MRI scan before that second set of biopsies is done. And typically you would meet with the oncologist